All right, so welcome everybody once again to the Venus Edge Vodcast that we do each issue. I'm going to tell you our topic today is a relatively easy topic. We've discussed this many times. I'm sure there's easy answers to this. In vein disease, what are the three things we don't know enough about? So while you're all thinking, what are the three things you may not know enough about, or in general, the vein world doesn't. Let me introduce our panel today. And we went completely outside the US, except for me, with our panel of experts. They're all from Europe. We have Kirsat Bozkurt from Istanbul. We have Marie-José Rijn from Rotterdam, Stephen Black from London, and Rick de Graaf, whose name is hard enough for me to pronounce, but I have no idea how to pronounce where he is. So Rick, can you tell us where you are?
Friedrichshafen, south of Germany.
He's Friedrichshafen, south of Germany. Okay, and I want to thank you guys for being here. So this topic is one that I thought would be good to get different countries' viewpoints and different people's viewpoints. All of you are vascular surgeons. Rick, you're an interventional radiologist. But everybody is a well-known expert in venous disease. So I want to divide it down a little bit in terms of the three things we don't know enough about. Let's first start out maybe with things that affect the quality of life of patients and or the development of the disease, the identification, and the prevention of recurrence. So, Stephen, do we know enough about the cause of venous disease? Is this one of the three things that we don't know enough about?
Well, you could probably break it down into more than three, but we'll stick with three for the time being. But yeah, I agree with you. I don't think we know enough. We don't know why some people get worse, why some people progress, why some people have poor outcomes from venous disease, and that's across the whole spectrum of it. So not just varicose veins, where we still don't know how to choose which of 100 people with varicose veins that are C2 are going to end up with C4, 5, 6 disease. We don't predict those very well. But even if you look at DVT patients and PTS, why do some people with iliofemoral DVT recanalize really well and others don't? And how do we predict which people will go on, if we don't treat them in the acute phase, to get really bad PTS and have no inflow vessels so you can never treat them, for example? So we don't know enough about venous disease, full stop, whichever way we try and spin it.
All right. Yeah, no, I agree with that. I mean, again, even though I said three things, we know that there's going to be many, many more than three things we don't know enough about. But I want to see if we can hone it down to some of the topics. So, Marie, a patient comes to you and they say, why did I get this? Why do I have vein disease? And we go through the observational list, right? Oh, your parents, job standing, maybe a little overweight, multiple pregnancies, et cetera, et cetera. But there are many people that have all of those characteristics and they don't develop vein disease. So what don't we know enough about to answer that question, for instance, for patients?
Well, yeah, I think that is one of the problems. So you can tell the patients that they have an increased risk, but that doesn't mean they will have to get it, even if they have all those things. And some people will get it and others do not. And others don't have any of those things and still they have it. It's probably like a sort of a genetic thing. So I think there's so much to learn there we really don't know. And it's sort of really frustrating, because if you would actually be able to identify the patients that will definitely get it or get worse, then you can intervene maybe earlier on or educate them better. But as long as we don't know who will get worse and who will get it anyway, then we can't really intervene enough. So that is sort of difficult and frustrating. I think there's still a lot of things we don't know in this area, actually.
Yeah, I mean, Rick, and you kind of come to them maybe a little bit later in the course of their disease, but the patient, how do you answer the question when patients say, what did I do wrong? When they come to you, is it something, or is it something I did wrong? And do we know enough to tell them, here are the 4 things you did wrong?
Yeah, actually, that is a question that I get. And just to clarify, I'm no longer the average interventional radiology, if you will, because I started my out-of-patient clinic and have my own beds and see the patients as they come to me, really firsthand. And that is something that they asked, what did I do wrong? And I said, well, let's look into your past and see. I mean, you didn't do anything wrong, but maybe we can clarify it, because they don't get that clarified when they go to a GP most of the time. And they say, so what happened before you got a DVT? Most of the times they don't even know when that moment was. But when you start talking, when you talk with the patients, then sooner that you come to a simple thing like immobilization after operation, definitely something in the family. I always do, of course, an MR, venography, and I find out if there's any underlying stenosis, and then you kind of see them relax a little bit when I tell them, you didn't do anything wrong, it's just your anatomy, right? Of course, I don't tell them that so many patients, but we can talk about it, of course, later, because one of the unknowns, so many not patients, but general people will have a stenosis but do not develop any venous disease. So yeah, it's usually a very interesting and long talk, but that's already a very important part of the healing process, if you will.
Yeah, no, I agree. Patients, especially the more and more educated they are, they want to know, A, did they do anything wrong? And B, can they do anything to prevent it from getting worse?
Mm-hmm.
So Kursat, do we know enough about what patients can do once diagnosed with vein disease to prevent progression? Can we give them, here are the 3 or 4 things you need to do so that you're not going to get varicose veins again? Do we know enough about that?
Certainly, many of them doesn't even have any clue what kind of things they can do in order to prevent it for progression. First of all, I believe the genetic tendency is the most important factor. In my patients, for example, there's a big amount of genetic problems. And also in our countries, relatively poor educated countries, the pregnancy rate is quite high. And unfortunately, many of those patients do not understand what's going on and what they can do. But the good point is, if you have enough time and if you can explain them very easily to use varicose stockings, avoid stable staying in a while, and they do better. But definitely they don't know a lot of things, and we have to teach them.
But do we know a lot of things? You are really, Stephen, would you say, are there things they can do? Do wearing stockings prevent development of future disease? No, I'm not talking about ulcers. Does it prevent development of new varicose veins?
Well, the data would not support that, would it? And I think there's been a number of trials now which by and large show that stockings do not alter disease progression and don't seem particularly helpful in prevention of complications either. So I would say the jury's still very much out in stockings. I think where perhaps stockings are helpful to some extent is if you get symptom change from wearing stockings and you get reduction in edema and your leg feels a bit better, it does speak to the fact that venous hypertension may be contributing to your symptoms. So it's sometimes a useful screening tool, but even that is very poorly evidence-based. So I think on the whole, an approach to giving people stockings or suggesting that patients should wear stockings isn't grounded in evidence and isn't grounded in data at all. So, we're not going to support the use of stockings in the new ESVS guidelines, and the NICE guidelines that came out from the UK reviewed that and found that that's why the recommendation was made that stockings should not be part of a treatment program.
Yeah, I mean, I it's probably, as you say, if it helps their symptoms, great, but they should not be under the illusion it's going to prevent progression or new disease from forming. So I want to kind of sum up this segment, which is we really don't know all that much about, what are the other risk factors, or why does somebody who have risk factors develop it and some people don't. So we don't have much of a knowledge, although you're all saying it's probably significantly in a genetic sense that people who develop varicosities, not just that they have a family history of varicose veins, but there's something else in the genetic sense. And as well, there's not much that patients can really do to prevent their progression of disease. And there's probably not all that much that we can tell them they need to do to prevent progression of disease, except perhaps at the end stage where, you don't want to necessarily progress to an ulcer, or you don't want to develop another ulcer. Maybe there are certainly things we can tell them they can do. But aside from that, is that a good or bad thing, Marie, that we can't tell them do this and you won't have varicose veins? Is that a good thing for us?
No, that's a bad thing. I really never like that. I mean, you want to give them all the answers. Yeah.
But I'm also saying, do we want to put ourselves out of business? Do we want to tell them do this and this and you'll never have a vein problem again?
No, of course, also not. But for the patients, it would be a lot better, definitely.
I'm being a little bit facetious. So let's get a little bit into, do we know enough in terms of the various treatments that we have? And do we need to know more to improve the results of our treatments? Rick, let's take the disease state of telangiectasia and or reticular veins. Do we know enough about the treatment aspect to get really good results?
Absolutely not. And definitely in my case, I mean, I have to be honest here, you guys really see that a lot. I work very closely with two vascular centers here around me for superficial veins. So they treat all the superficial veins, and when you get any recurrence, and I try to get them to involve me as soon as possible in the entire diagnostic process and treatment process as well. But for superficial vein disease, the patients not really, let's say, stay in my practice long enough, and also not for me to evaluate or treat that.
But okay, but where I was going a little bit more with Kursat, do we know enough? Do we have good enough treatments that we all feel, hey, we don't need to know more to get better results for telangiectasia and reticular veins?
I started to work in vein business maybe 30 years ago. I believe I feel myself very good in superficial truncal insufficiency, short saphenous vein, great saphenous vein. My results are almost very good. But if you are talking about C1 disease, telangiectasia and reticular vein, still nightmare for me. I mean, it's totally plastic business, plastic surgery business. Unfortunately, I had to do a lot, but still, believe me, it's the pain in my back. The reason is whatever I do, they're complaining. Whatever I do, they're complaining. And sometimes in the evening, after all of them, I started, oh my God, what I'm doing here? Something like that. Still, we are not very good in C1 disease, but clocks, I'm doing for the last 2 years. In the last 2 years, clocks made a difference. I mean, believe or not, but it works. That's why in the last 2 years, I like to do clocks as much as I can, and it works. Believe me, it works. The other treatments, I do a lot of foam sclerotherapy. I do a lot of liquid sclerotherapy. They worked, but the results are 70 to 80% good.
Right. I mean, Marie, what would you rather see? A patient that comes in with you and is pointing to all the different parts of their leg where there are these spider reticular veins and saying, I really don't like these, I want them to disappear? Or would you rather see somebody who has a ulcer, who has a post-thrombotic iliac lesion, and you can tell them what their results are going to be versus that C1 patient? Which patient would you rather take care of?
Well, yeah, I would rather take care of the ulcer patient,
Right.
but that is, mainly because you probably get better results and I have better treatment options and I can tell them more what to expect. Although for the patient, of course, it's a lot worse because you don't really want to have a venous ulcer. But it's true that the other patients have more cosmetic problems, and it's very much more difficult to get them to be happy. And it's more difficult to treat that, I guess. Although some patients, well, it depends actually. If you start with, big varicose veins and you have treated them, and then they stay with a little bit of reticular veins, and you treat that at the end, I think then usually they are happy with the results. But if their main problem is from the beginning of cosmetic, I think that's the more difficult patient to treat.
Yeah, I mean, it does, I mean, to me, as hard as I try, I mean, some patients are like really happy and some patients are like, well, this didn't work at all. And to me, it's frustrating as physicians. We want to get good results, and we have not progressed that well. Maybe with CLACS we have, but I still don't think we know enough, and I don't think we have good enough treatment modalities that are pretty predictable in terms of how the outcomes are going to come in C1 disease, and that frustrates all of us. Stephen, a favorite of yours, post-thrombotic infrainguinal disease. Do we know enough about it to get good results?
Short answer, no. I think the Access PTS study kind of suggested that some of these patients get good results when you treat them with that protocol, which I've tried quite extensively and not quite the same experience, but that's probably because in Access PTS, it's difficult to tease out where the improvement came from the superinguinal or infrainguinal disease alone, because the patients we put through that protocol have normal outflow tract and we treat them for pure infrainguinal obstructive disease. I think the problem with it is once you've got scarred up, damaged veins, it's quite hard to reverse that. You can't stent, they don't work. The role of May-Husney bypass in certain patients is tricky. I've had some good and some bad experience with that bypass. Venoplasty alone doesn't work. What are we going to add to this to get those patients better? So I think that really, which is a smaller group of patients, but that infrainguinal bypass, infrainguinal only disease with normal outflow tract, in other words, the ascending DVT that is not attributable to non-thrombotic iliac vein compression or May-Thurner, I think are a very difficult group to get good results. And I'm not sure that I have a great handle on what the best treatment strategy for them is.
No, I agree. I don't think we know enough about that. And so, Rick, let's think like, whatever you think you can do is going to happen to treat infrainguinal disease. They have normal superinguinal, or you've already stented this and they still have significant symptoms and/or an ulcer. Don't think about what's not going to work. If you could just say, I can magically develop a technique or a technology or something, what is it that you would want to be able to do for infrainguinal disease to make people better?
Yeah, definitely. I'm not talking about infrainguinal. I'm talking about almost infrapopliteal. I think that's the main issue, that the calf pump is not working really like it should be. And the problem is not really, so most of the time Profunda is pretty good, right? So you can go into Profunda, and we had beautiful results by angiography and beautiful flow, and still the patients did only marginally better. So all the blood is still hanging around somewhere downstream. So and so you got the flow from the upper leg. The patients do not really complain from that in the first place. They complain and they say, okay, my pain is really localized at the calf and that region. So, and I've got quite a couple of patients that I said, I keep you in the database, and I'm not going to do anything for you. I might do something, PT PTA and maybe with clot retriever, to get some chronic stuff out and stuff like that. And maybe even some focal stenting, right? But I specifically do not want to do that, because I think that in like 5 years, I will get the treatment from somewhere, from some innovative treatment that I can then treat you. So if I do that now and I thereby, make my future options impossible, I don't want to have that happening. So, and those are specifically the patients that I would like to treat somewhere, to get the inflow from the popliteal vein and maybe in calf veins to improve that. So, and if there's endovascular or not, I don't know. Maybe something from outside the patient, maybe something completely that I can't think about. I'm not. So, but I think that something like that should be developed to really get that calf pump working again, get the blood from the calf up north, because I think we are very close to getting it from there to the back to systemically. Yeah.
Yeah, no, I agree with you. That the end organ, so to speak, is that's damaged is below the knee all the time, the skin and that type of stuff. Maria, before I go to the next topic, let me ask you this. If we don't know enough about it, should our goal be to try and basically reconfigure the venous system? Meaning, can we get those blood vessels back to what they were before they had a thrombus in them? Wouldn't that be nice if we could clean out everything that's there and reline it with something that acts just like the veins they had before the thrombus?
Yeah, of course. I was thinking, if you would ask me the question that you just asked Rick, what kind of treatment I would want to opt for. I would actually want to opt for the treatment that everyone that gets a DVT would be treated as early as possible, get the clot out, and just never gets any problems from the DVT by itself in the first place. And even that is not possible, because if we would treat everyone with lysis or thrombosuction or things like that, then still some patients would have a scarred, not completely normal vein anymore. But I think it starts there, actually, to try to prevent that even from happening. It's just, you don't want to see them in this phase where it's already damaged, and I wonder if we will ever have a therapy then that can actually make them normal, completely normal and functioning again. So yeah, I really wish to be at the earliest spectrum of the disease.
All right, let's move on a little bit. We were talking about doing something physically to the venous system. How about, do we know enough about the non-interventional aspects of treating venous disease? And I'll talk about all kinds: venoactive drugs, anticoagulants, these type of things. Do we know enough about, and have we stayed so focused on what we can do to the veins, either destroy them, remove them, stent them? Do we know enough about the non-interventional aspect of treating vein disease? Kursat, what is it that we know, and what do you think we need to know?
First of all, in our country, we are lucky we have all of the available venoactive drugs. I mean, we have diosmin, hesperidine, diosmin, calcium dovastatin. I mean, we have the possibility to use all of them. For example, in the United States, in England, in Holland, you don't have these drugs available. We have all of them. Actually, we don't have enough data to support their effectiveness. We use it good for ödem relief. It's good for pain relief. It's maybe some sort of placebo effect. I don't know. It works. Specific in hot summer, they worked. But unfortunately, there is not enough data, good scientific data, to support their usage. But it works. It definitely works in some circumstances. In hot summer, if you can't use, for example, varicose stockings, yes, you can use them, all of them.
But I guess my question, is, and yes, what we have available now, but my question is, Marie, do you think our goal should be to, have we put enough emphasis on developing medications or something like that to improve venous disease and or to prevent progression of venous disease? Do we know enough about it? Or do you think we need to know more, and we really, that's where we should be focused?
Definitely, the current treatment possibilities are not enough, and we need a lot to do.
Yeah. No. So now let me ask Marie. I was asking the question too. Sorry, Mrs.
Yeah. No, I definitely agree that we need also more data on other techniques than, you know, the interventional techniques. Starting with anticoagulation, for example, we don't know hardly enough about that. And I have patients that have no indication anymore for anticoagulation and have a pain in their leg, and I just start the anticoagulation again, and that really helps them for their pain, and I don't really understand why. But I'm happy that it helps, so I prescribe that for them. And but I don't like to do things that I don't really understand and there's no evidence, just because I hear the patient say, oh, this helps me a lot. So there's so much actually in that area that we can develop more, and same with phenoactive drugs. We can't use them in the Netherlands, that's true. And there are results actually that points out in the direction that they do help. So yes, of course, I like to treat patients. I'm a vascular surgeon, but things like that should be developed better as well.
Yeah. So Rick, you're into thrombus removal, right? You like removing thrombus.
Oh, I love it.
Okay, good. At least we found one. We have found one thing you love. Plus, you love the lake that's behind you. But how about, is there another way? Do we know enough about it? Maybe another way of, quote, removing thrombus. And where I'm going is, have we harnessed the body's own thrombolytic systems enough to have them help us along with getting rid of thrombus?
Yeah, well, the thing is, of course, you can support our own system. You know, there's definitely a lot we do not know. Every patient in that way will probably have a margin of does it work well or does it not work well, and how are you going to adapt your treatment, your medical treatment upon that? So that will be extremely difficult. That's in the first place. The other thing is that I do not think that per se getting thrombus out or removing thrombus by the body or whatever is the solution. I think that as soon as possible to get it out. We had a very interesting discussion just about now at Thursday with Carsten and Noldersen, and he's sitting on very interesting data from the CAVA trial with MR venography of because we did an MR venography before, and the treatment you know, of the and also the conservative treatment arm, and then again MR after 1 year. Okay, so and he tells me that a lot of patients without the treatment got completely clean veins, right? So all fine and good, but what's doing that to the valves in the beginning of the you know, the solution process or the eradication process of the body? So I think that there's something to very early thrombus removal. And when I talk about early, it's going to be very early, and not when the patient comes to you with complaints and say, I've got 3 days complaints, and we think it's a 3-day-old DVT. It's not a 3-day-old DVT. It's many times 14 days. And then the damage has already been done. And you can see that on IVUS. You can see that MR venography, the vein wall is thickened. There's always adherent thrombus to the valves, etc., etc. So either you do an endovascular treatment. That's my, you know, that's what I'm thinking about. That's not science. Either you do an endovascular treatment or you support the body by get the thrombus out. Neither will help anymore. So, and therefore I think that the endovascular method, but as soon as possible, very early removal is the way to go.
Yes. So well, okay. Yes, the sooner the better. We know that. What I was thinking is we really have ignored I mean, patients always say, "Oh, I'm on anticoagulation. That's helping to dissolve the clot." That we know that that's not what's doing it. So, Stephen, I want to push you a little bit on this. Should we learn more about enhancing the body's own ability to dissolve thrombus?
I mean, I suppose that's one way of looking at it, Steve, is where should that attack come from? I mean, that's great if we can enhance the body's ability to dissolve thrombus, but I'm not sure any of the drugs or mechanisms so far have shown any promise. So, even the data suggesting that apixaban is better than warfarin is based on one study where the rate in apixaban was 50-odd% of PTS. Warfarin was 70-something%, which is the worst results I've ever seen in a study for PTS in a group of patients. So it kind of, the apixaban arm was no better than the control arm in ATRACT or any other study. So I don't think any drugs are demonstrably showing that they're better at enhancing clot resolution than others. And the problem is the end result of failure of clot resolution is collagen formation and scar deposition in effect. So chronic clot is scar tissue. That's what we're dealing with. And we haven't been able to fix scar tissue in any other field in so multiple things have been tried to attempt to make scars better or fix scarring or fix wound healing. So we've got to take it a step back to what Marie was saying, Kursat and others. Rick's an interventionist, so I'll discount his opinion anyway. He's just going to be focused on removing clot. The point back is if we prevent it and stop damage, then we're far better off than trying to do things that improve resolution of clot, because there's always going to be scarring attached with that. So the step before that, to me, is more important. So actually, Rick getting really good at removing clot, that's much more important than enhancing natural resolution of clot. And stopping it happening in the first place, much more important than that.
Right, but we know that, I mean, let's use the example, somebody, the first thing is somebody's given, if they're having a TIA or a MI or something, is, you give them aspirin. And there is some data that maybe that's going to help. So my point is, the moment that we found somebody's has thrombus, you immediately give them this pill.
Yeah, but that's the problem though. So TIA, stroke, everything else, there's a defined moment from normal to not normal. You got an hour to get them to treatment. It's from within the time of the event to when they start stuff is normally an hour. That's the whole ethos of cardiac MR, stroke, and everything else. We're never going to get there in venous disease because the onset of symptoms is insidious and never so dramatic. How often do patients present with gradual deterioration of their leg and they've got a big iliofemoral DVT with heterogeneous clot by the time they come? So, we're not dealing with the same beast. So to expect ourselves to be able to have a golden hour as you do in stroke or MI is not going to be the case. And until we have a much better way of determining who's at risk and who's going to get a clot, and how we manage that kind of what do symptoms look like when you're first starting to get a DVT. The first time you get back pain, come to the hospital, rather than waiting for your leg to swell.
Right. Okay. So I'm going to put each of you kind of on the spot. And then
we're turning the tide on you, yeah.
What? You can turn the tide on me.
We're turning the tables on you.
You can turn the tables on me. You could always refuse to answer and ask me a question instead. But then I'll stop the recording, so it won't matter anyhow. No. Marie, you are the king of the vein world. You have one decree. What?
Queen, I prefer.
Well, I didn't mean in that respect. I meant you're in charge of the vein world.
Correct.
Okay, I was trying to be like king.
Unbelievable, Elias.
One moment, guys. No, I'm way ahead of you. There's not a differentiation. King is either male, female, whatever, man, woman, whatever. It's like, the king is, in the old days, the king was, but I'm not saying that. Now you are the queen. Combine king and queen together. Okay, whatever. You understand. My point is, you're in control. You can decree this is what you want all of us to work on. The one thing that you feel is going to help your population that you're, you know, the leader of? What is it that you would tell us?
Well, I think what would really, really help is just to create more awareness. I think that actually for venous patients, we don't, well, we all sitting here, we do want to provide for them the best way we can, but I think they're still treated as, you know, oh, it's only venous disease. And it's not as important or as bad as when you get a stroke or an MI. And I think that if we create more awareness amongst patients, amongst physicians, that patients come in earlier, they take it seriously, but also other physicians, and that they know that there are ways to get clots out or to treat varicose veins better, because it's not just, you know, cosmetic thing, but it can really, really hurt them and can lead to ulcers and really lower their quality of life. We can put in venous stents. A lot of people still also don't know that. So I think that's the best thing we could do, is just to create more awareness.
Okay, you would decree awareness. Kursat, you can agree with Marie, but if you have some other ideas, let us know. Now, you're in charge, Kursat.
If I would be king, I try to persuade the parliament to spend more money for vein work. Still, Stephen Black is here. Still, we don't have wonderful, perfect stents for venous side. We don't have good drugs for venous pathologies. So first of all, someone should spend some money for research of vein pathologies. See, there is a big problem here.
Okay, Rick?
Yeah, well, when of course you think about, you know, awareness and prevention and everything, the problem with that is that the patients most of the time don't know themselves, right? So I was going that direction, but to be honest, there's not really something that I can think of that will help certainly the entire community of vein disease, and that we can prevent anything. I think we're pretty close. Maybe towards the high risk groups that you put more effort to get them to be imaged. So I'm thinking about all those orthopedic interventions that we will see. They can really go to and do some screening maybe, but it's so very difficult, especially also, I don't know, I mean, in the city maybe you have a better opportunity. Here in the rural area, the patients don't they don't go to doctors at all. They go to doctors when the foot start to get black, right? So that's not something that we can really get to the patients.
But you're in charge now, so you can decree the high risk people need to be screened.
Yeah, but I'm not king. Then I'm God, Steve. Then I look all over.
No, God is going to speak. God is speaking next, Rick. I'm calling on Stephen next. No, you're the king. We're going to ask God the next question. All right, Black, you're on.
Yeah, it's a tricky question, isn't it? Where do you start off in what you're going to decree? I think that I do still believe that the focus on understanding the natural history has got to be where it's at. So my first, once you start understanding who's going to get worse, who's going to not get worse, what are the risk factors, that's what I know. So I want everybody to be screened. If I'm going to decree something, everybody's getting screened in some way for venous disease, and then we follow them all for 10 years, and we know who gets a blood clot. So the pregnant woman, the orthopedic woman, the whole blooming lot, and then we start answering some questions and where they go. And the second component of that is take all these patients with vein disease and follow them all and see who gets worse, but accelerate that time frame. So if I get to be God, that means I can jump the clock forward 40 years and have 40 years worth of data immediately, which would be great.
That would be great for everybody. Well, look, I am, first of all, I am glad that none of you said we need to find a cure for, you would decree find a cure for vein disease. Okay, because then we wouldn't be doing this vodcast wouldn't be anything, and we'd be sitting here. So I'm glad about that part. But no, but in all seriousness, I think what I wanted to kind of get all of your thoughts upon here is there's really a lot of stuff that we don't know, and some of it's relatively basic. We're not talking about esoteric we need this little thing we need to know more about. There's just a huge amount of stuff that we don't really know enough about. And that's obviously why everybody's working in different areas. But I wanted to get your gestalt of the vein world, and I wanted to get it from an outside the US perspective. So I want to thank you guys for all of you for participating. And if something comes of this, that's wonderful. And I think people are already working on it. So that it's a good thing, but you brought up some other very interesting ideas where we maybe should go and where we should look. Anyone have any final thoughts, decrees, ideas, or anything? If not, I want to thank you for participating from different time zones, different countries, and we'll all look forward to the next Venus Edge. So thank you all.
Well, thank you.
Thanks, Steve.
Bye-bye.
Guys.
Thank you.